My name is Stephen Leeds, and I'd like to thank the committee for allowing me to present on my topic, should I offer my patient an endoscopic reflux procedure? My disclosures are that I do consult for Ethicon, which manufactures the LINX device, which is pertinent to this discussion. History of anti-reflux surgery is robust. The endoscopic forum has brought on many procedures, as well as a few procedures in the surgical forum. But over time, a lot of these procedures have fallen away, leaving us with about 4 procedures. However, there is one new kid on the block, which is the arms procedure, the anti-reflux mucosectomy, which I'll talk a little bit about. Just briefly, Stretta is a radiofrequency energy that's delivered to the lower esophageal sphincter. It's done through electromagnetic waves, and it has a usage of this catheter. It's done typically in a GI lab or suite, and takes about 20 minutes or so with an experienced proceduralist. The transoral incisionless fundoplication is an endoscopically created fundoplication where fasteners are deployed across the esophageal and gastric wall in order to create typically a partial fundoplication, where you can take a valve that looks like this, like a grade 2 valve, and make it look like a grade 1 valve. The arms procedure, like I said, is kind of the newest procedure out there, which you can see here based on the diagram, marking the areas that you want to resect. These are mucosal resections done endoscopically, which you can see in picture B. The retroflexed view is in picture C. And then after healing 6 months later, you can see a tight, non-compliant lower esophageal sphincter or GE junction, which will help with reflux. So the question is, which endoscopic procedure should you offer? And so we really need to talk about the treatment gap between surgery and medication. This means that patients that don't want to go on to surgery, or maybe a surgical procedure is too invasive for them, but yet medication is not providing the symptom control that it once did or that the patient desires. So you have this kind of gap between the two, where most likely these endoscopic procedures are going to fall and treat patients the best. Well, about 3 or 4 years ago, I did a literature review, and I was really trying to study what then was described as the GAP patients, which was the TIF, the Stretta, and the LINX. So I searched for all these PDFs, and I looked for % of patients off PPIs and the GERD HRQL to see which one was the best. And I created this very large database and was able to isolate patients in the Stretta, the TIF, the LINX, and then I did fundoplication as a control in order to look at the intervals reported in each study out to 10 years. We took the weighted means, which is in the yellow for each interval, and then we're able to graph the procedures against each other. And so you can see here that gray is the LINX, yellow is fundoplication, blue is Stretta, and the orange is the TIF procedure. And what you really see here is that the LINX and the fundoplication seem to provide a more linear type benefit. The Stretta is kind of all over, and then the TIF provides an initial good response to being off PPIs, and then over time does tail off. This was done for the GERD HRQL also. And what you can see here is actually very interesting. We added PPI in order to help understand the non-surgical or non-endoscopic benefit here. And you can see everybody usually starts at around the same baseline GERD HRQL score. And then the surgical procedures do separate themselves and essentially provide a really good benefit from the symptom relief. And then the 2 endoscopic procedures, Stretta and TIF, coupled together very nicely, and then the PPI being the least effective out of the group. We did this objectively also for % time of a pH less than 4. And so the green is the normalization. And here what you can see, which is also interesting, is that the surgical procedures will normalize the pH. The endoscopic procedures have some difficulty doing that. And then PPIs are kind of not very reliable in this type of study. This endpoint was used mainly because further back, this was the main endpoint before the Meester score came, which we were able to find some significant data on this. And again, you see very similar appearance. You can see again, the green is the normal, the yellow and the gray are the surgical procedures that do seem to normalize pH, and the endoscopic procedures seem to not normalize pH or Meester score. And then the PPIs also do not fall within the same range. So what does this mean? This means that the surgical procedures seem to be a bit more effective based on this data. The Stretta and TIF, which are the endoscopic procedures, don't regularly normalize pH. And here's the trend lines that we can see for the getting patients off PPIs. And so you can see the endoscopic procedures kind of tail off, but the surgical procedures somewhat remain a little more constant. But there's definitely weaknesses to looking at the data like this. So we had to eliminate a lot of data because the endpoints weren't broadly used, because we used we tried to use the most common endpoints, but those are not present in all studies. We had to use weighted mean because there was no other statistical method available in this instance, or the way the data presented itself. And probably the most important thing is that there's no account for the hiatal hernia. And I think this is really where the rubber hits the road when we discuss this topic. So the father of the hiatal hernia is Dr. Allison. I mean, he operated a long time ago, 900 patients. He followed 500 plus of them till the 70s. And what he understood was that the hernias come back, that we have a hard time repairing the hernias. And he was always saying, by rigid standards of radiology, we see about a third of the patients get a para and half of the patients get a sliding hiatal hernia. So we're seeing the hernia come back. Another study by Dr. Woodward, he had 4 groups, and essentially group 2 and 4 can be eliminated. They're very similar to groups 1 and 3, but you can see that the pH positivity, if you do just the crural repair or just the fundoplication, you only benefit about half the time from a pH standpoint. History did repeat itself. This study was done again, 40 patients, 20 patients got the hernia repair without a fundoplication. Another 20 patients got the hernia repair with a fundoplication. And just as you would suspect, doing both the pH repair and the fundoplication presented a much better response to reflux symptoms objectively. And so this does reflect in the subjective scoring system too. And so it brings on this two-sphincter hypothesis, and I'll tie this all together here in a second, but Dr. Louie did a nice study with high-resolution manometry after a full hiatal dissection in 18 patients. He put the manometry catheter down, then rebuilt the lower esophageal sphincter, and he looked at the crural closure and the nissen, and both of them contributed. And then the barrier pressure actually was more the crural pressure or the crural closure than the fundoplication. Dr. Pandolfino did a very similar study, went about a little bit different, where he used asymptomatic patients as well as GERD patients. And he was able to deduce that the patients that had GERD had a wider hiatus and their lower esophageal sphincter was easier to efface. And so again, we're looking at two components here contributing to reflux. So what do we know? Surgical procedures seem to be a little bit better than endoscopic procedures, considering the objective and subjective data that I showed you. And the hiatus really needs to be taken into account. Generally, the problem is that endoscopic procedures don't account for the hiatus. Unless you do a hybrid procedure, and please, we'll take that off the table for this point, but the endoscopic procedures focus on the lower esophageal sphincter only. And so the endoscopic procedures, probably for that reason, have a difficult time normalizing pH. They can improve quality of life, which we've shown, but normalizing pH is a little bit difficult. So when we talk about recommending an endoscopic procedure, you want to maximize the success of the endoscopic procedure. So first of all, I don't think it's fair to compare them to a surgical procedure, but we do it anyway because we're talking about a reflux patient rather than isolating the patients out into categories. And so what are we talking about then? If we have nothing to compare them to, how do we promote an endoscopic procedure? Well, does it matter which fundoplication we use anyway? Because if we're just talking about augmenting the lower esophageal sphincter, does it matter with a fundoplication, because that's where all the data is that we study. And we see this larger study that was done. This was a meta-analysis of RCTs, so great level 1 evidence. So the dysphagia is a little bit better in a partial fundoplication, but GERD control and Demeester score, there was no difference between the two fundoplications, which if it doesn't matter what fundoplication you do, why do we do one over the other? And there's other manuscripts that show that there's no dysphagia and no changes in dysphagia rates between different partial or complete. So really there's no difference in what fundoplication you use, especially when we look at the literature. So if the type of the wrap doesn't matter, then probably the augmentation of the lower esophageal sphincter is probably less important. So you can use Stretta, TIF, or the ARMS procedure, but the main difference is likely the hiatus. So addressing it and repairing it seems to be the most important part. So even in this patient here, very narrow hiatus, you can see the aorta in the background. There was probably next to no hiatal hernia in this patient, but we repaired it anyway to snug up the hiatus and help with the reflux barrier, aside from augmenting the lower esophageal sphincter. So when we recommend an endoscopic procedure, we need to identify the gap patients better. I think patient selection for an endoscopic procedure needs to be done better. And so we use the endoscopic procedures for these patients. That would probably be the ideal forum for them. Again, not including the hybrid type procedures. Use patients where the hiatus isn't a factor, or at least isn't a factor as much, where we don't see an endoscopic or radiographic hiatal hernia that needs to be repaired. Probably doesn't matter which endoscopic procedure, in my opinion, we use in these patients, but you have to repair the hiatus, which is probably where you get that confounding or synergistic benefit. So otherwise, I think you should expect recurrence of symptoms if you don't take into account the hiatus. So my recommendations are probably that it doesn't matter which endoscopic procedure is used, given the hiatus isn't taken into account. It's finding the right patient that is probably the most key, and then aligning the expectations with the patient about what symptom relief or objective benefit they're going to find. Thank you for allowing me to present.